Okay, hello everybody. We are live with the DSD Airway Day, an idea that came up a few weeks ago about this topic that I believe I'm learning so much about it, and I strongly believe this is one of the hottest topics in dentistry right now. I think this crisis has pushed us into the position of thinking about the work that we do and how we can impact people's life, how essential dentistry is, how vital it is what we do for people, what is more superfluous, what is non-essential about what we do, and what are the things that can really change people's life. Now, we know that dentistry is a profession that can really affect positively people's life and change people's life in beautiful ways, from the aesthetic standpoint, from the psychological standpoint, from the functional standpoint, from the biological standpoint, from the systemic standpoint. But if I could think about the things that me as a general practitioner could improve by adding to my offerings, adding to my toolbox, I would definitely add this specific topic as a priority number one. It's not only about becoming an expert on this, but I think the most important thing is to addressing the issue, is to knowing the basics, knowing as little as possible to identify the patients that can actually benefit from treating these issues. So we know the experts in our countries. We just need to understand what we need to know. What are the basics that we need to know to raise the yellow flag, to raise the red flag, and to, before jumping into other treatments, at least in an ethical way, addressing this issue with our patients and showing that we care beyond whatever is our specialty, that we are comprehensive diagnosticians, that we are global physicians, we are healthcare providers in the whole meaning of the sentence, healthcare providers. So that's why I'm so excited, and I'm putting so much energy, me and the DSD team, on putting a list of experts together. By the way, I'm extremely proud of being able to invite these people and actually have them accept this invitation last minute. And super proud, super happy, super excited, because I'm going to learn more than anybody here. I'm going to be here moderating and asking questions, but I really want to learn from these experts. We're going to have 6 top doctors on this topic today. So for the next exactly 8 hours, I'm going to interview 6 doctors from all over the world. We're going to start with Dr. Derek Mahony from Australia. Then we're going to go to Dr. Jeff Browse, one of the top names in the US. Then Rick Robley, another great name on this topic in the US. And then we're going to finish with 2 Brazilians, Dr. Eric Toller and Dr. Otávio Sintra. So I'm extremely excited, and I want to officially welcome our first guest, my friend, Dr. Derek Mahony, that I don't see for a long time. So I'm super happy to see you, Derek. I'm super happy and proud that you accepted my invitation. Very grateful that you're here to share with us your knowledge on this topic. Please say hello to the DSD community and give us a little bit of a background. Who is Dr. Derek Mahony? Welcome.
Thanks, Chirstian, and thanks very much for the invite. I'm very honored to be on this platform, and you're dead right. I mean, the future of dentistry is airway. I always have a saying in my lectures, think airway first and teeth last, right? And that's a hard message for some people. I mean, my background as an undergraduate studying dentistry in Sydney, we weren't exposed to anything to do with airway at all. And even when I did my postgraduate training in orthodontics in London, not one lecture. I was just very lucky at the time to meet during my master's research with Professor Sten Linde Aronson from Karolinska Institute in Stockholm. And he was the one who made me understand that a lot of the malocclusions I was seeing were related to mouth breathing in children. Now, I know tonight we're going to focus more on the adult and the prosthodontic interface, right? But a lot of this stuff is preventable if you understand that most of the malocclusions that we see are somehow related to posture and airway and poor nasal breathing, et cetera, et cetera. So my role as an orthodontist is obviously to do interceptive treatment in that regard. So my background, I have a degree in dentistry, I have a degree in orthodontics, I also have a degree in dental sleep medicine, right? And those 3 degrees kind of helped me kind of put it together. And I'm glad you have Jeffrey Rouse as the next speaker, because the prosthodontist I work with in Australia was his student when he was studying in Texas. And he's really focused on airway. I mean, how many prosthodontists do you know that do full mouth reconstructions but never assess the sleep or the history of apnea, et cetera, et cetera? I think this is all coming to the forefront now. Yeah.
Nice. No, I'm very happy that we were able to put this together. Hopefully we're gonna initiate some thoughts here that will make people stop to think and really invest time. As you said, we have very little exposure to this topic, and we're gonna talk about how this issue affects humanity in general. How many people in the world could benefit from meeting a professional that understands a little bit more about this topic. And I was the same. I was never exposed to this topic during dental school, during my career as a restorative dentist, even during my career learning interdisciplinary treatment planning. This was something that came later on, and I was lucky as well to meet people like you, like Rick Robley. My father was always into it and always working with specialists in this area in the office. So I was kind of lucky to have this background from my father. But I want to start asking you something very philosophical, I would say. If you could bring these 4 terms in one sentence, and the 4 terms are airway, snoring, quality of sleep, and well-being, how would you create a beautiful sentence to introduce this topic using these 4 terms together?
Look, we perform as adults during the day based on how well we sleep at night. We know that. And we don't want to get too deep into this, but we know our body's always in a flux between parasympathetic and sympathetic system, right? Now, we're all in Western world stressful jobs, okay? Our sympathetic system is in overdrive. It produces cortisol. And, if you really go back and you look at the basis of all this, even if you want to look at something like yoga, deep breathing, getting air through the nose, not through the mouth, the release of nitric oxide during that process, all of this helps that parasympathetic system to kick in. I would say, you can't separate anymore TMD problems, poor sleep, bruxism, sleep apnea. I think they're all part of the triangle. And I like Jeff's, one of his classic articles was on, he called it the bruxism triad. And he talked about wear of the teeth. He talked about the sleep apnea, and he also talked about gastric reflux. And that's a subject I want to explore a little bit more, that, don't just think that someone who does a sleep study and has no apnea, right? So in other words, they have less than 5 episodes, they're not breathing, don't have sleep-disordered breathing problems. They have a lot of nasal problems. So I think it's important that people understand that if you have a thing called upper airway resistance syndrome, you're not sleeping well at night. You're constantly awake, and therefore your performance during the day and your body is always in overdrive. So I think this is bigger than fixing teeth, right?
Now, definitely. And to this topic, I wrote a little quote from a non-expert on the topic, but from an excited fan of this topic. I wrote a quote for my team last week, trying to bring lines to promote this day. And I said, if you want to have a beautiful smile, you can get veneers. But if you really want to smile, you should invest on the quality of sleeping, right? So this is exactly to what you're saying. You can have, and I will address this topic a lot with Rick Robley. That is another guy that has been talking about this, And when I was listening and learning from guys like you, it's beautiful to see that faces. When you look at a face that is breathing well and it's sleeping well, it automatically looks better, regardless
Yeah.
of the aesthetic parameters.
Absolutely.
You look better. And even the aesthetic principles that we learn, and coming from the aesthetic restorative background, you know, we learn how to fake aesthetics with restorations, you know, how to create the illusion that that person is really healthy by creating a beautiful cosmetic smile with restorations. And in fact, it's a much better result when we understand how to actually move the pieces to the right position instead of trying to fake them with restorations that are trying to create the illusion of the right position by mimic this position. So it's beautiful when you go deep into what means beauty and you understand, again, what you know, function and aesthetics are always together, right?
Correct. And as an orthodontist, I did the first 10 years after I graduated treating class 2 malocclusions by thinking it was buck teeth, you know, and we retracted a lot of incisors. I pulled out a lot of teeth. And I think I compromised not just the facial aesthetics, but definitely the airway. Now I get it a bit better. I understand that most of these problems are the lower jaw needs to come forward, right? We all understand divine proportion. And let me tell you, when you look at an attractive face with a broad arch, hardly any malocclusion, let me tell you, they have a good airway. Trust me, they have a good airway. Good face, good profile, good airway.
Yeah, and I was coming back to that point, trying to build some slides, you know, because as you know, I'm all about smile design and how to design smiles that are in harmony with face. So I was thinking, you know, when we design smiles, we usually want to have a beautiful orofacial harmony integration from pure aesthetics. I'm talking. So I realized that when we design a beautiful smile in a beautiful face, when the face looks good and the mouth looks good, you have a wider smile, as you said. You have a nice profile and you have good vertical dimension. And what you guys say is that don't try to recover that because of aesthetics. Recover that because of the airway, and aesthetics will just be a continuation of it, right? You create space like this, you create space like this, and you create space like this. And these 3 dimensions will give you the airway, and it's naturally going to look better as well.
Because
correct?
To me, if I straighten someone's teeth and I don't fix their airway, I think it's like me rearranging the deck chairs on the Titanic, right? Ultimately, what have I done for that patient? I haven't done them a great service. And I think it's really, really important. And I mean, there's if you're going to have more speakers, invite Juan Quintero from Florida, excellent orthodontist, airway focus, you know, poor old, I shouldn't say poor old, but John Mew, he's 93 years old. And a lot of the stuff that he talked about many years ago, and people shot him down saying, this is crazy, blah, blah, blah. It actually makes sense.
No, it's growing. So, and I want to start with two questions here, actually, to put importance, 3 questions to give importance to this day for people that are watching, to put this in perspective, right? I want to ask you, what percentage of adults remains undiagnosed for this issue, for obstructive sleep apnea? You know, what are this is the first question. I'm going to just repeat the 3 so people see the perspective, and then you can have some time to explore 3. So what is the percentage of people out there going to the dentist and the dentist not diagnosing this issue, right? This is the first question. Second question, signs and symptoms associated with adult sleep apnea. You know, what do you see when you see a person, you say, this person has issues here? And what are the long-term effects? This is very important. What are the long-term effects of undiagnosed sleep apnea, and in particular, the morbidity of patients who remain undiagnosed and untreated? So please, to give importance to this topic, give us the answer to these 3 topics.
Maybe can I start with the last one, because that wakes everyone up, right? Okay.
Yeah.
I can send anyone who's interested 3 very good long-term studies that show that if you're an adult and you have moderate sleep apnea, not even severe, but moderate sleep apnea that's not diagnosed and treated, you will die 10 to 15 years earlier than someone who doesn't. That's huge. What else in dentistry can we say, hey, we might add 10 to 15 years in your life? Christian, you've successful, you've done everything in your career. What would you pay for 1 extra year of life, healthy life, versus 15? So, you know what I mean?
Yeah.
Now, as far as statistics of how many people remain undiagnosed, it's huge. I mean, I can quote American Sleep Apnea Association that say 22 million Americans are estimated to be suffering from OSA, right? And they're not being treated. So that's leaving them at risk of conditions more than bruxism and wear of their teeth, but cardiovascular problems, huge correlation between that. And as we know in America, maybe not so much in Brazil, where anyone who's not beautiful is destroyed at birth in Brazil. Is that right, Christian? But in America, in Australia, my God, the obesity is through the roof. And what goes with obesity goes sleep apnea, type 2 diabetes, depression, right? All of these things. So a much bigger picture. So absolutely, depending who you read and what country, 70 to 80% of people who have this condition are still not diagnosed, okay? And those who are not diagnosed, the worst case scenario is they're going to have a mortality rate much worse than their peers. So this brings us into who is at the forefront of diagnosis? Who is the gatekeeper of the airway? To me, it's the dentist. We spend more time looking in someone's mouth than any other health professional. But what are we trained to do? We're trained to look at the teeth and the gums, right? What we should be looking is in the back of the throat. So let's talk about signs and symptoms an average dentist should be able to pick up.
Derek, let me just summarize what you just said. Let me summarize because I want to emphasize this.
Yeah.
You, with my non-expertise approach, you are saying that 70 to 80% of people suffering of this issue is not diagnosed. This is huge.
Correct.
I think you mentioned 70 to 80% of this problem is like 70 to 80% of the people out there missing the front central, and the dentist not seeing that the person is missing the front central. Exactly. By the way, you can live super healthy without your central, but with this issue, the second statement you mentioned is that people are dying, not severe problem, average problem, medium level problem. People are dying 10 to 15 years earlier than they would be if this was treated. And then the other thing is that if you say that if they were treated, it means there are treatments out there. There are treatments out there that can help 70 to 80% of the people out there. And you also mentioned that the dentist should be the one, because we see our patients at least once a year, many times twice a year. We are inside their mouths, and we should be diagnosing this, and we should be giving this huge benefit to our patients. So now brings us to the next question. If this is so big, so important, so relevant, what a general practitioner, what is the minimum amount of information that a general dentist should know? Not to treat, but just to identify and refer. That's all we need to do, right? If we don't want to spend 10 years of our lives becoming experts on this topic, we just need to find who is the expert in our city, and we need to become good diagnosticians. We need to look, we need to make the right questions, the right exams, and identify the issue and refer. Do you agree?
Absolutely. And I think what every dentist should do, now again, we're talking just about adults tonight, but my passion is the pediatric OSA, right? But what everyone can do to all their adult patients is just give them a simple sleep questionnaire. It's called Epworth Sleep Scale, right? And it was developed in Australia. I'm pretty proud of that. But it's the world standard. It's a series of questions with a score rating. It doesn't cost you anything. It doesn't cost the patient anything. The questions they ask, on average, between a scale of 0 and 3, 3 being always, 0 being never, would you fall asleep in front of the TV? Would you fall asleep after lunch? Blah, blah, blah. And that gives you a very accurate guide of who could be at risk. That's number one, right? That's without even looking in the mouth. Right.
So what is the name of the questionnaire?
It's called the Epworth Sleep Scale. And I'm happy to send everyone the Word document. It's very easy to patients to use. So that's someone like a screening questionnaire. All right.
It should be mandatory at every dental first appointment, huh?
Oh, I think so. I mean, my good friend of mine is both Michael Gelb and Harold Gelb, and I love the way Michael says some things. He says he's probably a little bit more outspoken than me, right? you know Michael, right? And he says in future, dentists will not be able to do a restorative case without looking at the patient's airway, right? And he says, well, they can, but that could increase their risk of a lawsuit because more and more people understand this is out there. So I think you've also got to, look after that. But after the questionnaire, that gives you a guide who may be high risk, and then look a bit more closely at that patient. And this is where, most of the signs of this are evident in the oral cavity, more so than anywhere else, right? So some of the things we see in the oral cavity, the tongue is going to have scalloping on the side of it, right? So it's showing you the tongue doesn't fit in the current jaw size, shape, position. So where does it fit? It goes at the back of the throat, right? And what else can we see? We look in the back of the throat, we see the uvula is red, it's edematous, highly inflamed. That's classic snoring, right? We look more so in children, but also sometimes in adults. We look at the tonsils, and in fact, a very famous American anesthesiologist by the name of Malanpati, he came up with a good index for patients. You just literally get the patient to say ah. You don't put the tongue down, just say ah, and you look in the back of their throat, right? And it's easy for a dentist to identify a Malanpati 4 and 3, which is very high risk of sleep apnea. So looking in the mouth, I mean, and again, there's 10 things on a checklist, like you fly a lot. I'm sure you hope that every plane you get on, the pilot has done a checklist, right? Before the planes take off, right? So I think dentists should have an airway checklist, chair side, right? And I don't want dentists to think that the snoring patients are going to be those big obese guys with no chin, right? That's the low-hanging fruit. That's the easy pick. It's a lot of the people, like Chinese males who are like thin as that. They have a higher tendency to sleep apnea. They have a higher tendency of class 2 jaws. So I think you've got to look at every individual like that. But what do we see as bruxism?
Yeah.
I said the classic.
Very,
sorry. Yeah. The classic giveaway.
I have friends they have issues. Yeah.
Yeah. The classic thing is when I do my orthodontic program, I have about 90 students and they do a 3-year program with me, all dentists, right? And then I make them do their own sleep study during the program. You'd be amazed, 70% every year after year, have sleep apnea, 70%. And they don't know about it, right? Okay?
Yeah.
So, I think it's interesting for anyone listening, if you're a non-believer and you have some of these symptoms, like what are classic symptoms? Do you need to go to the toilet during your sleep? For children, they wet their bed. For an adult, they're going to go and urinate. So it's not normal to go and pee once, twice at night. That's a classic sign of sleep apnea. What else? Ask a patient, how long does it take you to get to sleep? Now, if the answer is, 2 minutes, or I'm asleep even from my head hits a pillow, that's an early sign of sleep apnea. Or if a patient says, it takes me 20 minutes to get to sleep, that could be insomnia. So we have these conversation starters, and it's called stop bang is the little mnemonic. So S for snoring, T for tiredness, O for obesity. It's a really good, look, I'm not sure what you talk to your patients about when they're in the chair, but most dentists talk about boring stuff like the weather or the football team, how they're going, right? Why waste time? You could have a conversation starter that could be saving their life. Do you know what I mean? And it could start with, do you or your partner ever notice snoring or gasping for air when you wake up? Or do you sleep 8-9 hours and still feel unrefreshed the next day? These are conversation starters, and I think every dentist should have these conversation starters because this is an epidemic. This is really a big thing,
Yeah, no, and you touched a point that I will probably invite you on another opportunity to talk about because it's related to pediatric and kids on this issue. That is as huge, and as we know, everything that is identified early on can be better treated, on an orthopedic process, really guide the growth and treat these things, as little as 2-3 years old. You can see that, you can identify that. I'm saying, because my son, 3 years old, he's definitely going to be class 2. He already snores at 2 years old. He has all these things that if we know right now, we can treat, and hopefully as an adult, he's going to have a better airway because we identify that. Now, since the topic is adults, of course, we have the early, if you see this on kids, there's many things you can start doing it. Now, in adults, what are the limitations? What are the tools that we have today? How can we really help people? Are the treatments that we have nowadays effective? Because people, I met many doctors, many dentists that told me, Chirstian, this is an important topic, but the tools available are not that good. And since, I don't see things being effective, I don't know exactly how to help my patients. What do you think about that?
Oh, no. I think it's the opposite. I mean, it's all about the vertical dimension. And I know recently on some of your posts, you've been combining some lectures in Seattle with Coyce, right? Now, Coyce is a master at vertical dimension. And, what I learned from doing Coyce's seminars, when an adult comes to me with crooked teeth, I can't just assume that I'm going to line their teeth up and maintain the same vertical. Because what happens as we get older, our nose and chin kind of grow towards each other. The more restorative dentistry you have, the more vertical dimension you lose, and that predisposes you to airway. What I was taught in dental school, when people had full dentures, we were taught to tell that patient to take their denture out at night to aerate, but that's the high risk of them having apnea, because when their dentures come out, what happens? Their whole face collapses and their tongue goes back. So if any time they should wear their dentures, it's when they're asleep, right? So I think it's actually very important, because dentists, we can measure the vertical dimension of the patient. We have so many ways of assessing their profile, and all the things you've taught. If you have someone whose maxilla is a long way back, you have to compensate like hell to give them some good nasolabial angle or some good vertical display of incisor. But if you bring their maxilla forward, wow, that's a whole different person, a different airway, a different balance of the face. So I think a lot of this is very much related. And, I know you do a lot of work with Invisalign. I'm so happy that more and more cases are using aligners rather than old school orthodontics, because when you're doing elastics and a lot of wires, man, you're constricting that arch form. You're retracting a lot. One thing good about aligners, what you see is what you get. You can get that expansion. They're very good for that. So I think that's a good way forward, right? And, there's going to be controversy in the next statement I'm going to say, but let me tell you, the older type of orthodontics that I was taught, pull out the teeth to make the room and then pull them back with elastics to get the incisors, to me, man, that is bad for airway. That is really bad for airway.
So you definitely believe that the know-how is growing, the solutions are improving, the treatments are getting better. We have better tools and better experience today to treat the airway than 20 years ago.
Absolutely. And here's the thing, though. You know how I said 80% of people maybe are not diagnosed? Even those who are diagnosed, the 20%, many of them don't get long-term treatment. I'll tell you why. Because in Australia and many parts of the US, the only treatment has been CPAP, all right? Now, CPAP, we know it's very effective. It was developed here in Australia. My professor, where I learned a lot of sleep medicine, Professor Colin Sullivan, he developed CPAP. But here's the problem with CPAP. Compliance after 6 months is abysmal. After 1 year is almost non-existent. You understand? Whereas dentists can make oral appliances. And let me tell you, if you look at the research published in the last 5 years, for moderate, even severe apnea, the oral appliance is as efficacious as a CPAP, but the compliance is good. So if you want to get into this field, you've got to learn how to establish correct vertical dimension and AP of the mandible to open up the airway. And your next speaker, I keep raving about Jeffrey Rouse, but man, he knows his stuff, right? can I use that word in Australia? I don't know. He knows his shit. Is that a? I'm not sure in Brazil what the equivalent in the saying, but man, that guy knows.
We're gonna have a combination because after you comes Eric Tuller, that is one of the best otorhinos from Brazil, specific on this topic, and then after him comes Jeff. So it's gonna be a beautiful. And then Rick Robley, that is the guy who really woke me up for this topic. Yeah. That is combining, aligners with SFOT and surgical procedures and orthodontic. Yeah. We're gonna have a beautiful mix of experts here, and I want to get into some of the questions that topics that you told me before the interview that I think is very good, more technical, more clinical.
I'll say one more thing. Yeah. I take my hat off. I take my hat off to Brazil when it comes to orthodontics, right? I spent a lot of time in Brazil. Previous life, previous wife, the whole deal, right?
Yep.
But Brazilians do really good orthodontics. Why? Because they do a thing called dentofacial orthopedics. What's her name? Wilmoz. They brought a lot of the Frankels of the world, the Bimblers. Yeah. They came to Europe. They came to Latin America, and it's the Brazilians that really embroached this early treatment. And not only that, you know what? Oral myology. Let's talk a bit about that. Myofunctional therapy. In Brazil, it's like a specialty. And the papers and the research that comes from your country, you should be very proud in the field of orthodontics and myofunctional therapy. And guess what? It absolutely influences the airway. Absolutely.
Yeah.
Sorry, I had to add that before I forgot.
Thank you. No, we have many great professionals. And as I mentioned, my father always had in his team an otorhino, an orthodontic surgeon, and a orthopedist, orofacial orthopedist, dealing almost specifically about this. So this was my veneers and my restorations were always surrounded by these topics, and it was a beautiful environment to grow as a restorative dentist, learning from all these people. And airway was always around it. We're gonna have here as well. The last interview will be with Octavio Sintra, that is the #1 pupil from Bill Arnett in Brazil. The face, airway, and bite concept, fab concept. So Octavio will talk about that as well from the orthodontic perspective. But let's go to the technical.
The most successful treatment, long term, if you really want it, is bimaxillary advancement osteotomy. Right? You bring the maxilla and the mandible forward and the chin. My God, you look better, you breathe better. I mean, I was the victim. No, I'm so passionate about this because I was the victim of the worst orthodontics in the world, right? At 14, I had headgear, I had 4 teeth out. Everything's back here. So I know what not to do, and I know what I need, but I'm not brave enough to put my hand up and do the bimax advancement.
But you touch a topic. Actually, I have a question. I was going to do it later, but since you mentioned that topic for premolars extraction and bringing everything back, etc. One of the guys who sent me a question asked, the treatment of when you have this problem of bringing everything back and extracting teeth, how efficient it is to do orthodontics and expand back, open the space, replace the teeth. Is that a good option?
It's a very good option. And in fact, 2 big guys in the world doing that. One's an orthodontist. His name's Bill Hang. I don't know if you've come across him. He has a website. It's called Face Focus. He's in private practice in California. My God, he has come up with this concept which he calls extraction, retraction, regret syndrome, right? So in other words, he retreats all these adults like me by not doing surgery, but by slowly developing their arches and reopening their 4 bicuspid extraction spaces for implants. And he gets amazing results. And what I like about Bill, he doesn't just measure cephalometrics, he measures their sleep and their airway, and he shows the improvement. Another guy, like Hang, a dentist, his name, Victor Avis, right? Definitely. They're, in answer to whoever asked you that question, yes, if you have a committed patient. But this is why I'm more passionate about pediatrics, because in pediatrics, you can fix the problem before it becomes a problem, right?
Yeah.
You develop the jaw, you bring it forward while the jaw's growing. Then you don't need the orthodontic surgery, and you don't need years of orthodontics to open up the spaces. But yeah. Absolutely.
But I think just as a main message of the whole day today, it's for us professionals to keep in mind the space, space, open space, more space, space, and space, right? Absolutely. So the 3 dimensions of space, whatever we do in somebody's mouth that is reducing space will generate a problem probably. And everything that we do as if a first main goal or as a secondary goal of what we are doing, if this is actually opening space, we are giving an extra benefit to our patients.
Absolutely. Yeah.
So you mentioned regarding, there's a big connection between sleep and bruxism, sleep apnea and bruxism. And when you're treating severely worn dentition patients, when you look at those teeth, the typical worn dentition patient, how do you know if this is a sleep apnea issue or stress-related issue? If it's just grinding or if it's because of the sleep apnea?
So this is where a sleep study comes in, right? Because there's a very famous researcher. His name is Gilles Levine. He's from University of Montreal, and he's coined the term sleep bruxism. And that's different to the classic bruxism we were trained in. When I went to dental school, we were taught anyone who grinds their teeth, you give them a flat plane splint, right? But what the research now shows, some patients, the flat plane splint worsens their airway. So it actually increases their bruxism. And how many patients, Chris, have you made a splint for and they grind through it every few years, you make them another splint? So I say to patients, listen, you grind your teeth, and most of them will deny that. You know that. They say, what are you talking about? I never grind my teeth, And you look in the mouth and you think, oh my God, you do. But anyway, and then you say to them, I can make you a bit of plastic, and what it's going to be like is if I see a friend hitting their head against a brick wall, like many times, 20 times an hour, hitting their head, and I come and get a pillow and I put it on the wall and I cushion. I'm not stopping him hitting his head. I'm just softening the blow. That's what most splints do, right? So the sleep study, I don't want to get too technical into sleep, but there's a type of induced bruxism which follows the microarousal or the apneic event. And you can see it clearly on a sleep side. Now, those patients need a forward repositioning splint, right? They're the ones that need the vertical change, and they're not ones that you can just put some plastic at a certain height and one size fits all. There are still the stress-induced bruxism. We know bruxism is multifactorial, and yes, in adults, a lot of it's to do with stress. But let me ask you, what causes stress? Extra cortisol. What causes cortical release? Being in the sympathetic system. What increases sympathetic system? Poor airway. So I think we're answering the same question.
It's connected.
Yeah,
everything is connected. Yeah, and we know about all these appliances that are definitely something that is improving and helps a lot. Now you mentioned something about, I believe that the key to make a good appliance is, regardless of the technology or the method or the system that you use, something that the doctor needs to take over is how to reposition the jaw, how to register that position to design the appliance. And you call the sleep bite, Yes, so how to take proper sleep bite is a challenge.
So there's many techniques, and I've tried them all, right? And it all comes back to the work of Rob Ricketts and his phonetic bites, right? So, depending who you listen to, some people do neuromuscular and tens the muscles and get a vertical. Steve Olmos, I don't know if you've heard him speak. He used a provocation test. I still like using the phonetics, the 66, 67, 68. And then you just look at that vertical dimension as a guide. If you want to get really accurate, you can buy machines like pharyngometers that measure the airway in 3D as you take your bite, But the bottom line is you can't just keep bringing your jaw forward and think that every time you bring it more forward, you open the airway. There's a sweet spot. So if you bring a jaw 5 millimeters forward and it's good on your reading, and then you go 7 millimeters and it drops, then you know that the vertical you've picked. But most people only do the vertical. The AP. The vertical is just as important. And I think again, what is it? Who's the guy? Frank Spears, right? He's the prosthodontist. Spears with Jeffrey Rouse, they came up with that. I think it was called the Seattle Protocol. I don't know if it's still called that, but back in the day when I did those courses, that's what they called it. And basically, that Seattle Protocol is very good because you don't just hop in straight away with one appliance. You make some temporary orthotics and you test lots of things. The sleep, the airway, upper resistance, if you believe in this sort of thing, and that really allows you then to maybe target the correct dimension. So I use a lot of provisional sleeps with various verticals and various protrusion before I get the sleep bite correct, and that's important.
So you mentioned this circle, this vicious circle, sleep quality, stress, the grinding down your teeth, airway, sleeping bad, stress, grinding down your teeth, airway, and it goes around and around. There's another issue you mentioned as well, TMD disorders. What is the relationship between TMD disorders, bruxism, and obstructive sleep apnea?
So the majority of TMD orders that we see in the general population are related to parafunction, right? Clenching during the day, bruxism at night, overloading the joint. I mean, there's a lot of intracapsular problems related to traumas. I mean, they're the less percentage. Most of our patients who come with TMD, it's myalgia because the muscle that should be resting at night is running a marathon at night, okay? And this constant overload of the joint fossa is what causes this. And I think a lot of it is loss of posterior vertical dementia. I mean, how many patients do you see routinely, Chirstian, who come in with their first molars removed as kids and they have TMD problems, right? Et cetera, et cetera. So I think it's beautiful that you've brought the aesthetics. And the good thing, what you brought in is what people want. Everyone wants their teeth whitened and they don't care about their periodontal disease, right? Everyone wants to look more beautiful and more attractive, but they don't care about their airway. But now what they realize is that they want the ultimate. The airway is part of the deal. You want to, what's the secret of youth is good sleep. And not 20 hours of sleep, but like 5 hours of good sleep to get into sleep where your body refreshes, what we now call stage 3 non-rapid eye movement, right? To get to that sleep, you can't if you're having nasal. You're going to have an ear, nose, and throat doctor talking, right? I think. Most of the patients I see, their snoring is not base of tongue; it's a nasal valve collapse, right? And they have this thing called upper airway resistance. So in other words, they're not getting to deep sleep. And if you don't get to deep sleep, you can sleep 9 hours and still work unrefreshed. But your sleep study will show you don't have apnea. So there's two bits. There's the upper airway and the lower airway. We can look in the mouth and see a lot of the lower airway problems, but CBCT is an important tool to look at the nose and the upper airway.
Now, you also mentioned, because these new terms, it's like we conventional dentists, we need to learn a new dictionary of terms that we need to be acquainted to be able to even talk to the specialist about these things. You also mentioned the difference between sleep disorder breathing and obstructive sleep apnea. These are two different things, right?
Yeah.
And what exactly?
So sleep disordered breathing problems include snoring without apnea, include mouth breathing as an example without apnea, include upper airway resistance, what I was talking about. But unfortunately, for many years in the research, everyone has only measured just the apneic event. Right? So what we call AHI, apnea, hypopnea, index. Now, if you don't have apnea, hypopnea, that doesn't mean you necessarily have perfect sleep. So nowadays we look at sleep disordered breathing in totality, and sleep apnea is one of the comorbidities of that syndrome. So I think we need to measure more. Now, one thing I'll say, when dentists want to get in this field, remember, we, without a medical degree, without a sleep physician training, we can't make the diagnosis of sleep apnea. We still need to work with our sleep physicians and do a proper sleep study. But we can at least guide the patients in need to get the sleep study, right? Mm-hmm. And in the past, when I was referring people for sleep studies, they had to wait a long time. They had to go to a hospital. Now with the new machines, you do it at home, and it's wireless technology. It's Bluetooth stuff, right? But the information you get is just amazing. So I always say to a patient whose Epworth sleep scale comes back with high numbers, listen, it's not going to hurt you to sleep in your own bed one night with this wireless machine. And I could be wrong, but if I'm right, you are going to thank me because I'm going to change your life, literally change your life. And do that before you start your major restorative, before you start your major orthodontics, you know?
I think it's a great service and great ethical service, great care, but also great business and great marketing for you as a doctor to actually address and show that you're beyond what the patient was expecting, right?
Yeah, absolutely. And I think everyone in Australia complains, we're losing patients because they're going to the corporate. In Australia now, it's become very corporate dentistry where big companies have lower fees and they attract the patients. But if you are that only dentist who took the time and picked up a serious medical problem, every other dentist didn't, no one cares how much you're going to charge. You're going to be their doctor because you've gone that little extra. You become their oral physician rather than just their dentist, you know?
I love that term. You become, if you have a doctor, if you have a heart issue, and you have a doctor that is the doctor on issues and he's taking great care of you, you're not going to go to the chain down the road, to the DSO of the heart down the road because it's a little cheaper, right? You create loyalty, you create the feeling of scarcity, you create the feeling of real care beyond the teeth and the gum. You show the patients that you show your community that you are really the physician of the mouth, their oral physician, that your vision about the body, about systemic health is there, right? I think it's just to be able to really increase your offerings, you know, and differentiate yourself on a period of crisis, recession, competition, and DSOs, and all things that are threatening doctors, are making dentists to feel threatened. I think we need to step up. We need to be one step ahead. We need to be ahead of the game because whoever is doing that doesn't even have time to worry about competition.
Yeah. In fact, I had a referring dentist who did 4 veneers for a patient, and beautiful, did really nice job, but they kept breaking, you know. And the second time she replaced them, and the third time she said, you know what, this has got to do with your bite, right? And referred to me. And I looked at the patient, and the overbite overjet was normal. There's nothing. But I looked at all the other symptoms. I saw the tongue flopping over the airway. I asked, do you snore? Yes. Do you have to go to the toilet when you are sleeping? Yes. Does your wife find that you wake up gasping for air? Yes. You know, so we did a sleep study, and that patient had severe airway problems, right? And then when we fixed the airway problems, all of a sudden, the third time, my referring dentist redid the veneers. Guess what? Absolutely stable. So I think what we realize is a full mouth reconstruction, when you look at it on, and I know you did your initial training as a dental technician, you do beautiful work, but when you put that reconstruction into the mouth, it may fit perfectly, but it doesn't remain pristine because the muscle force is working on it. And if the muscles are not balanced and unhappy, that restoration is going to fail. And I think this is so important for people to realize.
Yeah, everything is connected. There's no way you can disconnect the pillars, you know, and I really believe that airway will become a much bigger pillar. You know, people on the restorative world, we talk about the biology, meaning the gum, you know, function, meaning the bite. If it's biting, if teeth are touching, class 1, all good. You know, function, aesthetics, biology, and structure of the teeth and roots. We are very in this little bubble in the mouth, and I really believe that airway opens our mind to something much broader. What is beautiful It makes dentistry so much more beautiful, you know.
Yeah.
Really, you feel so much more proud when you expand this world of just restorative dentistry, and you see how powerful it is to be a dentist and how you can change people's life. And to finish here, Derek, to be a very pragmatic question that I want to ask you, you know, correct me if I'm wrong, but if I'm a young dentist or even a general dentist, it's never too late to say, okay, I love this. I'm going to start studying this. I'm going to become good at this, right? That's one path. You can at any moment, at any given moment of your career, decide that this is going to become your thing beyond what you are already good. Airway treating, identifying, diagnosing, and treating the airway and sleep disorders can become your next new thing, etc., etc. So that's one path. The other path that I always like, whenever I'm talking about something very specific, I always try to give some take-home messages on two paths. This is going to become my thing, and I just need to know the basics to refer, because I know a very good guy down the road, and he's going to become my guy on this thing, right? So as I said, we don't need to be great at everything. So if you can give a couple of tips of next steps for these two type of doctors listening to us. If I want to be an expert on this topic, what would be my next thing? Where do I look for the information? Give me some suggestions on how do I build my career on this topic. And the other path, if I don't want to become an expert, I just want to know the minimum. What are the main take-home messages that you would give to me? What are the next steps for me to stop missing the point here and providing this type of care to my patients?
Yeah, good point. So I think if you don't want to do a lot of extra study, right, and do, I always think a formalized training program. There's many, if people want to email me, depending on where in the world I'd recommend. You know, I'd recommend Spear Foundation in the US. I recommend courses in, you know, in countries, people I know who do this stuff well. But it does involve some dedication in learning about sleep and learning about applying.
New specialty, right? Yeah. It's a new specialty you need to be willing to become, yeah.
Yeah, and I really will use this opportunity to congratulate the American Academy of Dental Sleep Medicine. They're doing a wonderful job. They have a accreditation program, and if you go through that and you pass it, definitely you know what you're doing and you can treat a lot of these patients. However, you may just want to do the best for your patient and continue to do what you enjoy doing. Well, then start with some screening, right? You need to have that checklist. It's that 10-point checklist, and it includes the sleep scale. It includes something really simple. For $50 US, you can buy a pulse oximeter. And the pulse oximeter tells you if the patient's having oxygen desaturation during the night. And that is very, very simple, cost effective, right? But it's just screening. So you can then say to the patient, hey, you know what? From your scale, from looking at your mouth, from your partners reporting what you do when you sleep, from everything, I think you need to do a sleep study. So let me refer you to my colleague, Dr. Blah, 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 you know? But I think, why would you just want to, as you refer patients and you see they come back and they're feeling better, I think it would motivate you to want to learn more. And I think the secret of sleep medicine is not going to be CPAP. The secret of sleep medicine is two things: oral appliances and myofunctional therapy. And who are the most quick people to do oral appliances and myofunctional therapy? Is the dentist. So what a great, I mean, what's that Martin Luther King famous saying, I have a dream, right? I have a dream that one day every dental program in the world will have a big emphasis on airway. So you graduate as a dentist, and this is nothing new. I think that's the future. Your world travel, you know everyone. You're the guy to carry the flame, huh?
I don't know if I can carry the flame, but I can put a lot of fire. I make a lot of noise. Wow. Fantastic, Derek. This was I think a great, perfect opening for this day, for this session. You know, I want to thank you again for your time and for your insights. I really want to keep this conversation going, stay more in touch with you, discuss other ways to explore this topic, you know, and bring more information to people. I definitely want to see how we can explore the pediatric topic that you mentioned, maybe schedule an interview in the future about it. But from the bottom of my heart, thank you so much for your precious time, and just for everybody watching, it's a final message from you, not only about airway, but as a dental opinion leader as you are. Give us all a good final positive message to our community, Derek.
I think we all do the best for our patients. I've never met any dentist anywhere in the world who doesn't do the best for their patients. But my take-home message, think airway first, teeth last. How's that?
Perfect. I'm gonna make a note, because at the end tomorrow I'm gonna bring all the highlights of all the interviews, and that sentence will probably open the whole session.
Okay. Good stuff. All right. Nice to speak. And if you're doing more of these programs, remember, next time let's do pediatric OSA. That's a big one. That's huge.
We will do it. We will do it.
Thank you.
Thank you. See ya. Stay safe.
You too.